We have an administer one here.
We know that one's down.
We need to have another bag of blood. Sorry.
That will get him intubated after we open his chest wall.
From there, they stick the finger in and go, it's the most technical part of the procedure. Hey everybody, my name's Nate. I am a working paramedic, and today we'll be taking a look at a wild video of a patient that was shot in the chest. He ultimately made a full recovery, and we'll be taking a look at the care that ultimately saved his life. The original video was posted with the patient's consent, and nothing I say in this video is intended to be disparaging of the crew, the patient, or anyone else related to them. I've also linked the original poster in the description. This crew did an excellent job managing this case. If you find this video educational or entertaining, please consider giving it a like and subscribing. That way I know to make more of this kind of content. So without further ado, let's get into it.
Building's gonna be set up at the.
Hi. So we have an administer one here. Going through. He has lung sounds. Blood pressure is 85/62.
Okay.
We see that the crew that was first on scene already has vitals and a basic assessment done, as well as they have the patient on the cot. They report that the patient has been shot in the left chest and has bilateral lung sounds, as well as a blood pressure of 85/62. Those odd numbers mean they're using an auto cuff, naughty naughty. The patient still seems to be doing okay, all things considered. He's not yet in cardiac arrest, which is a great sign. When you're shot in the chest, there are at least 5 big things that can go wrong immediately. The bullet can cause massive bleeding by damaging structures such as arteries, veins, and organs. It can cause damage to the lungs, resulting in a pneumo or hemothorax. It can cause damage to the heart or its structures, or it may cause damage to the spinal cord, causing neurogenic shock. And at this point in the case, unfortunately, all of these are still on the table. Initial management of this patient includes identifying all of the patient's wounds. That might mean getting him what's called trauma naked, where you take all the clothes off so we make sure we didn't miss a bullet hole, which is shockingly easy to do. Then, when we know where all of his wounds are, we're going to control any major bleeding. And if we find any sucking chest wounds, we're going to seal them with what's called an occlusive dressing. This is to prevent a worsening pneumothorax from air getting sucked into that pleural space and collapsing that lung.
So do you see how what I'm thinking
I'm dying.
with the way that the gunshot wound is?
Please,
In through here.
please, please.
He's got crepitus under his left axilla.
Sounds good.
Feel this crepitus here?
Yeah. Okay, well, we know that one's down.
Now that we're in the ambulance, the patient's becoming a little bit slow to respond. That indicates to me that his shock state, or his lack of blood getting to where it needs to go, is starting to progress.
Yeah. All right.
Hold the side.
We're losing it.
Get your lines, get your blood.
I've got a 16.
Sounds good. Let's hook our blood in. You can come over to the side.
Blood's working.
Good. Let's get those pads on, but that's fine.
Yep.
But his cardiac arrest will be from exsanguination.
Sure.
Ready for
Pass me the IO.
and let's get, and then as soon as we get the IO in, let's get him ready for intake. Momentarily. Well, we have more lines in. Yep. Let's just get him ready for all his monitoring. Make him naked.
Little pressure, bud. All right.
The crew places a tibial IO, a large bore IV, and a central line, as well as multi-therapy pads for defibrillation should it be needed later. All of these points of IV access, the central line, the IO, and the IV, are to facilitate performing a massive transfusion of blood into the patient. Hopefully, this will prevent him from going into cardiac arrest.
You ready for blood? There you go. Holy crap. I'm watching this bag turn itself inside out.
Going to the LZ as well. Finish out your driving.
We need to have another bag of blood. Sorry.
This bag's empty.
All right, sounds great. We'll see what his pressure is. We're going to probably open his 5 ketamine's given. Let's drop our sucks and be ready for that. We'll get him intubated after we open his chest wall. You ready, Joe? How many
What are we
thoracotomies
saying
has he
with
done?
that?
Now that they have vascular access, they start administering whole blood to replace some of what was lost. You can see they use a commercial device to warm the blood up to body temperature, as well as a nifty device to push blood into the patient. It's like a blood pistol. You go psh, 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 and it shoots blood into the patient. It's pretty neat. They also prepare to intubate the patient by administering the sedative ketamine to help calm everything down and get him ready to put a breathing tube in. At this point, they've identified the patient has a tension pneumo or hemothorax, meaning that the lung is being collapsed to the point that it's compressing blood vessels and reducing the blood pressure. It's essentially putting an extra workload on the heart by compressing all of the tubing that blood usually flows through in the body. The solution to this is a needle or finger thoracostomy in the field. It's pretty neat. We like poke a needle into their chest or like cut a hole. It's pretty cool. You'll see it in a second. I will warn you, this is a form of a surgical procedure, so if you're a little squeamish, you can skip this next part.
We'll give it one.
Downward, there you go. Perfect. Good enough. All right.
In.
Feel pop? Okay.
Yep.
Pull apart, hard. All right,
There it
significant hemothorax on the left. All right, put your finger in there and just get it as wide.
We see them make an initial incision in the chest wall of the patient. They then Leroy Jenkins the clamps into the patient's chest. This allows blood and air to flow out. From there, they stick the finger in and go, it's the most technical part of the procedure. All of this relieves the tension pneumohemothorax, allowing the patient to not die in the back of the ambulance. No one dies in the ambulance. We see that little rush of blood that came out of the incision site. That's all that pressure that was built up being released out of the chest. That is a very good thing for this patient.
Because we don't need it until we're ready. Let's put the cannula on to get him doubly oxygenated. I got you.
94 down here on ours.
Okay, sounds good. Well, he's 96 on ours. I don't think he's got an oxygenation problem. I just know that when we intubate it, he'll rest.
99/60.
Perfect. So we got blood going into both.
That one going over there.
Keep it on.
Okay. We got another blood pressure going, 100/63. I'm convinced that with the continued infusion of blood products that he will hopefully, and we're going to resolve his tension pneumo, he won't arrest. We got one more blood pressure.
I got 119/71, sir.
Okay, let's go. Let's push this acetylcholine, Nick.
Sucks.
After more blood administration, this patient's blood pressure improves to the point that intubation is safe. The patient is then given a massive amount of oxygen to make it safe for him to stop breathing briefly while the crew intubates him or places a breathing tube into his trachea. At this point, the patient's already been sedated with ketamine, so they push the paralytic succinylcholine, which will temporarily keep him from moving so that they can get a really, really good view as they visualize the vocal cords, and put a breathing tube into the trachea.
TXA, do you?
No, sir.
All right.
I got 104/58, that's with 100%, heart rate 82.
All right, epiglottis. Let's go a little
Deeper.
deeper. There you go. All right. Sure.
Coming out.
We have an end-tidal waveform over there.
Yes, sir. Entitled 43, good waveform.
Excellent. I'm going to take this cannula off. You hold.
They use a video laryngoscope, which is where you have a camera on the end of a laryngoscope, and you can use that to visualize the cords without having to look at them directly. They then use that to guide an endotracheal tube into the trachea, where they can ventilate the lungs directly. As a note, the patient's eyes are open for this, but he is very well sedated, and he likely doesn't remember any of this. The original poster included this incredible piece of cinema.
An Air Medical Services helicopter crew assumed patient care from ground ANS crew. Continued warned full blood transfusion during flight to reach 11 watches.
Much better.
All while keeping it educational. As we're told in that incredible scene, the crew then transfers care to an air ambulance who continues the care they've already provided. They take him to a regional trauma center and he goes straight to surgery. Ultimately, everything we do in the field for these major trauma patients is to increase their chance of surviving to and through surgery. If they die in the gutter, a surgeon can't save their life. So all of these fancy procedures are awesome, but really ultimately they need to be in front of a surgeon. And again, if we didn't do these procedures, they wouldn't make it to the surgeon, so they're very important. But an important point to remember with these cases is ultimately these patients need more surgery than we can do in the back of our ambulance. And without all the care provided in this video, I'm completely confident this patient would have expired in the field and never would have made it into surgery. But as it stands, he was discharged from the hospital 2 weeks later and made a full recovery. Massive, massive kudos to everyone who took care of this patient. And a massive thank you to the original poster of this video. I'll link him in the description. He does a lot of medical videos. He's got some really, really cool content, so go check him out. Again, please subscribe if you want to see more stuff like this. If this video does well, then it will indicate to me that I should make more videos like it. So thank you so much for watching, and I'll see you in the next video. From there, they perform the finger part of this finger thoracotomy, where they stick the finger in there and go, It's very technical.